I'm Dr. Evan Dellon, a professor in the Division of Gastroenterology and Hepatology in the Department of Medicine at the University of North Carolina School of Medicine in Chapel Hill, North Carolina. Today, I'll answer your most frequently asked questions about eosinophilic esophagitis, or EOE. We'll start with some questions about diagnosis and monitoring. First, if biopsies from the proximal esophagus show 15 eosinophils per high power field, but distal biopsies do not show anything, or vice versa, does this help you treat this as EOE or GERD? The short answer is the location of the eosinophils actually don't help us really with our differential of EOE and GERD. So by that, I mean you can have 15 or 30 or 100 eosinophils distally, and it could be either EOE or GERD, and you could have the same number proximally, and it could be EOE or GERD. It's really a situation where you have to take the entire clinical presentation into account. So if it's 15 eosinophils distally and there's LA grade C esophagitis and hiatal hernia, and symptoms are of heartburn, regurgitation, and some dysphagia, that would be much more consistent with GERD. The same situation would be also consistent with GERD, even if the distal esophageals or biopsies are normal and there's 15 EOs proximally. The LA grade esophagitis, hiatal hernia, and symptoms really would drive your thinking. On the other hand, if it's a patient with a food impaction and dysphagia, several concomitant atopic allergies, and 15 or 20 eosinophils in the distal esophagus and nothing proximally, that's very consistent with eosinophilic esophagitis. So you have to use the whole picture of how the patient presents, as well as your clinical judgment. It's important to remember that EOE and GERD can also coexist, and so sometimes you have to treat both conditions. There are times where you may need ancillary reflux testing as well, but it helps to support the presence of GERD, and it in and of itself doesn't help you distinguish all the time between EOE and GERD. The next question is whether decreased eosinophils will equate to decreased symptoms and decreased signs of esophageal fibrosis. And the short answer to that is no. And the reason for that is the eosinophil count on histology and other biologic measures of disease activity, like other histologic features and the endoscopic features, do not always correlate well with the clinical symptoms. And this is the main rationale behind the recommendation, not only to assess symptoms after treatment, but also to repeat endoscopy and histology. And this dissociation can happen in a number of ways. So first, you can have decreased eosinophils and still a lot of symptoms. How does that happen? Well, it could be that whatever treatment, whether it's diet, PPI, steroids, or biologics, is working, and you are decreasing inflammation and decreasing endoscopic features. But if there is still a fixed stricture, you can have persistent symptoms. If there's a complication from your therapy, like candidal esophagitis from topical steroids, you can continue to have symptoms. And so that's one way that there can be a dissociation. The dissociation can also happen the other way. So you could have high levels of disease activity, so high eosinophils, prominent endoscopic features, and minimal symptoms that the patient might report to you. And this could be because they may alter the way they eat to minimize their symptoms. If they are avoiding foods that stick, if they're eating carefully with chopping their foods into small pieces, chewing slowly, drinking a lot of fluid, these are the so-called impact behaviors, it can really minimize and decrease their symptoms. But when you do an endoscopy and biopsy, you're going to see a lot of active disease. And then the other way it can happen would be if you dilate the esophagus. Someone will continue to have active biopsies and active endoscopic findings, but improve symptoms because the dilation will improve symptoms without changing the underlying disease activity. So again, this is really why it's important not to just assess symptoms alone and make decisions based on that, but to assess the symptoms in the context of what's going on biologically with how the esophagus looks visually and what the biopsies look like. The next question is whether fibrosis can persist despite histologic remission. And the answer to this is yes. You can have a therapy that is very effective for anti-inflammatory therapy. You can have normalization of the eosinophil count and of other signs of inflammation on biopsy. But a severe stricture can certainly persist because all of our treatments may not have a very strong anti-fibrotic component. or that antifibrotic component, if it happens, may take a very long time to actually see an effect. So again, this is why someone who might say, yeah, I've been taking a treatment and I don't feel any differently, really needs an endoscopy, because the reason for persistent symptoms might be persistent fibrosis. The next question is about assessing histologic response and discussing what eosinophil count to really aim for in practice, and how do you assess remission. And notes that many studies and many providers talk about remission threshold of 15 EOs per high power field, but in recent clinical trials where drugs are being approved or assessed by the FDA, a threshold of 6 or fewer eosinophil counts is being used. And so this is an important question, because histologic response and the peak eosinophil counts on the biopsies are certainly important to assess to understand treatment response. Now, generally, I would say most people recommend aiming for an eosinophil count of 15 or fewer to look for histologic response. Now, of course, we all know the normal number of eosinophils in the esophagus is 0, but it's not practical to get every single person to 0. For drug approvals, however, the FDA has chosen to use a more stringent threshold of 6 or fewer, and that's primarily related to methodologic issues, so that you could see actually a change between someone who might enter a study in the 15 to 20 range, and you really want to see them get as low as possible. Having said both of those things, in clinical practice, it's really something to individualize. And again, it's something that it's a question of assessing what company the eosinophils are keeping. So for example, if somebody starts at a very high level of eosinophils, say 200 per high power field, and they're able to get down to 20 EOs with a therapy, but they feel really well and their esophagus looks much improved visually, that may be an excellent response for that person. But in contrast, somebody who starts at 20 eosinophils per high power field and gets down to 14, but has persistent symptoms, persistent stricturing, persistent endoscopic findings of inflammation, you're not going to be happy with that treatment response in that patient. So in practice, we've got to take the eosinophil count with a little bit of a grain of salt and put it into context about what's going on with that patient and what treatment they're on. The other thing to remember is I think there's increasing recognition that the eosinophil count is not the end-all be-all in this condition. We know that it doesn't really correlate with disease severity. So for example, somebody who has a count of 200 isn't necessarily 10 times as severe as somebody who has a count of 20. And there are a lot of other things going on in the biopsy besides just the eosinophil counts. There's proliferative changes, there's barrier changes, there's fibrotic changes. And so again, all of those things need to be considered in context when you're thinking about assessing treatment response. Let's move on now to some questions about actual EOE treatment. The first one is for diet. So what patients choose dietary therapy over other modalities and why? So I would say in my practice, about a third of patients end up choosing dietary elimination therapy, but that really varies widely by practice setting. There are some practices where nearly everybody is treated with diet therapy, and some practices where nearly nobody is. Much of this is due to patient preference. Patients really need to be motivated and partner with doing dietary therapy because it's something they need to alter with every single aspect of their diet, every meal, every day. Additionally, there are some practices where providers don't either have the expertise or the infrastructure to do diet elimination, and that may play a role as well. The recommendations are to work with a nutritionist or a dietitian when you do diet elimination therapy in EOE. And so practices without access to that may not do dietary therapy very frequently. So in my own practice, I use a shared decision-making framework where I talk to patients about medical options and diet options and what's entailed with both, and then come to a decision with the patient about what is best for them. In general, there are some guidelines, I would say, and things to know about patients. So you really have to understand a patient's situation for them to choose diet therapy. Somebody who travels frequently for work, who might be in college, living in a dorm and eating in the cafeteria, who might have irregular work hours, or who's someone who doesn't have the ability to cook for themselves or get to specialty grocery stores may not be a good person to do diet therapy. And sometimes in families, it may impact how much the family can support that patient, whether it's a child or whether it's an adult. So these considerations come in to diet therapy as well. But it's an excellent therapeutic option in patients who are motivated and have the support to be able to do these treatments. The next set of treatments um, relate to PPIs and steroids. And a common question is, how frequently are PPIs used? And if so, if you are using them, how long would you use them? How and when would you assess for treatment response? Because we do know a fairly good proportion of patients will be PPI refractory who have EOE. And to that last point, it's true, about 60% or more of patients will not respond to PPIs, and we don't have good predictors about who may or may not have that response. But nevertheless, these medications are very safe, very well tolerated, and readily available. And so many times in my practice, this is a first-line option for me, and often the first treatment I use for patients who have EOE. And I will use double dosing, so twice the approved dosing. So for example, omeprazole 40 milligrams a day rather than 20 milligrams a day. My practice is to treat patients for 8 to 12 weeks and then not only assess their symptoms and clinical response, but to perform an upper endoscopy with biopsies so I can assess how the esophagus looks, how the disease activity appears visually, and get those biopsies for histologic response and other histologic features. That will allow the decision as whether to continue the medication or maybe change and go to the next medicine. The next question is there a role for combination therapy of PPIs and steroids? Now here there are not many data related to this. So um, we're a little bit stuck in terms of what experience and also common sense would say. So for example, in the scenario I just presented where a patient is put on a PPI, they're assessed after 8 to 12 weeks with endoscopy, a biopsy, and clinical assessment. If they have had no improvement in symptoms, no improvement in endoscopy or histology, I think the most reasonable approach is to stop the PPI, switch to a topical steroid, and treat for, again, about 3 months with another repeat endoscopy and biopsy to assess treatment response. If at that point there's still no treatment response, some people might consider doing a combination of the two therapies. But again, there's not much data on that, and most of our steroid response data are actually in patients who are PPI non-responders. Now, it's common, though, that you may have a patient who says that they feel better on the PPI, but when you do the endoscopy and biopsy, they still have signs of a lot of disease activity. In that situation, it may make sense to continue the PPI since they are having some clinical benefit. Perhaps they have some overlapping reflux or they're having a partial response. Add a topical steroid. Again, repeat an endoscopy and biopsy in about 3 months and look for your response. If it's totally normal and the patient is doing great, in that situation, I often will stop the PPI and see how they do on steroids alone. But sometimes the patient may want to continue both. But my general rule is to try to use one therapy at a time when I'm assessing initial response and then move to consider combination therapy down the road in more difficult to treat patients. Another question is how do we know if the eosinophils are controlled if you stop a topical steroid after 8 weeks, and can you just follow symptoms? So here, I think the same concept applies for either monitoring diet or monitoring PPI therapy, which is that if you're using a topical steroid and doing an initial treatment course of 8 to 12 weeks, it is important to assess symptoms, but it's not sufficient to do that. You really have to repeat that endoscopy and biopsy because of this dissociation between symptoms and endoscopic findings and histology. And you need to understand the picture of how a patient's responding in all three of these domains, the symptoms, the endoscopy, and the histology. So that's really how you would know. And you would sort out whether a patient is having a complete response in all those domains or an incongruent response. And then you've got to work on why the response, say, to symptoms may not be as good as the response to the biology. Perhaps that's because there's a stricture. Perhaps there's visceral hypersensitivity or esophageal hypervigilance or other reasons as well. The next set of questions will involve biologics and dupilumab specifically. The first question is would you consider dupilumab as a first-line treatment in patients with EOE with a strong family history of osteopenia or osteoporosis? Now, this is a very interesting question because I think what is being implicitly asked here is that there's also a worry about possible intolerance or side effects with PPIs and topical steroids. Now, both classes of medications, corticosteroids in general, of course, are well known for their impact on bone health, and there have been some purported associations between PPIs and osteoporosis. I think for related to the PPIs, that is not a common or strong association, and so I would not use a osteopenia or osteoporosis risk for PPIs to drive my decision making on dupilumab. Now, a strong family history of this in terms of a treatment with a topical steroid, again, I think you have to consider that the topical steroid is low dose and minimally absorbed with little systemic exposure. We have really no data to suggest that topical steroids impact bone health when used correctly over the long term. But, for a young patient being faced with years and years of possible steroid exposure, it may be a consideration. Now, on the flip side, what do we know about dupilumab as a first-line agent? And the answer is not that much. In the clinical trial program, both the phase 2 and phase 3 studies, all of the patients had failed PPIs. And actually, the majority had previously been treated with topical steroids, and about half of those patients had been non-responsive to topical steroids. And so, based on that, there's very little data to support dupilumab use in newly diagnosed first-line patients. Now, however, if there are strong contraindications to PPIs or topical steroids and dietary therapy isn't an option, in this situation, maybe you're worried about calcium and vitamin D intake, then yes, I think because dupilumab is FDA approved for EOE, it's worth a discussion with the patient and a discussion for whether the medication could actually be approved for use. The next question is, once dupilumab is given to a patient, how long should it be continued? Is it forever, or is it until the symptoms resolve or the biopsies become normal? And then related to that is, when do you need to perform an endoscopy to look at whether to continue or stop the treatment, and how might you wean the medication? So this is all, I think, very good questions about the practical aspects of dupilumab use. And so for right now, we have strong clinical trial data through 52 weeks for use of dupilumab, but we also have data for many years on the related conditions of asthma and atopic dermatitis, where the safety of long-term dupilumab is established. We also know that in general, when patients stop dupilumab, just like for any other treatment that's stopped in EOE, ultimately the disease will flare in nearly everybody. And so right now, if dupilumab is giving a benefit for the patient, probably it's a medication that needs to be continued. Now, I think we can't tell anybody right now that it's a forever medication, but that for all patients, you have to continue to evaluate them and assess whether the treatment they're on, whatever it is, whether it's dupilumab, diet, steroids, or PPI, is appropriate for them to continue given their current situation. Now, in terms of monitoring it, though, generally, you're going to want to repeat an endoscopy within 6 months of starting dupilumab. During the clinical trial program, the primary outcomes were assessed at week 24, so 6 months, and sometimes approvals are contingent upon a response at 6 months. So I think in many patients, you can treat for 6 months and assess the response there. And what do I mean by assess? Again, it's going to be a clinical assessment of whether they're improving and an endoscopy with biopsy to look at the endoscopic severity and whether there's histologic response as well. Now, that interval really needs to be individualized. In a patient with food impactions who's had a severe stricture and who's needed dilation, they may need to be scoped earlier, like you would do normally anyway, at about 3 months for continued esophageal dilation, and to make sure that they're having an initial expected response. But we do have data from the clinical trial that the longer you stay on the dupilumab, you see ongoing increasing response. So we see response rates not only maintained between 6 months and 1 year, but actually in some cases, ongoing improvement. Yeah, so then after saying they're doing well at that 6-month time frame, what do you need to do next? Well, you certainly monitor them clinically. I think the choice about when to do the next endoscopy, again, is going to be individualized based on how severe that patient's been, what complications they've had, and then in some cases, whether demonstration of ongoing response is needed for ongoing medication use approval. In terms of weaning the dupilumab, if for some reason you need to stop the medication, there is not a need to wean it. The medication can just be stopped. It has a long half-life, and so it will still be in the patient's system for several months. But you don't need to wean it to stop it. It can just stop. A different question is whether in the future we may be able to go from the weekly dosing to less frequent dosing for long-term maintenance with this medication. And that's a very interesting question. We don't have any data on that right now, but I'm hopeful in the next couple of years, we'll start to see reports from centers that are using it in real-world practice that may help us inform our use of this medication long-term. Well, that will conclude our discussion today. I hope you found this helpful for your clinical practice. I appreciate you listening, and thanks again for tuning in.